Hi, my name is Nadia Harbeck. I had the pleasure of chairing the Menarini Stemline Symposium here at ESMO Breast 2026, which dealt with the question, what do we do in second-line hormone receptor positive, HER2 negative metastatic breast cancer?
The second-line setting can be broken down into those patients who lack a biomarker, those patients who have either PI3 kinase, AKT, or PTEN pathway alterations, or those patients who have an ESR1 mutation in their tumor. We have several trials that have reported out benefit of single-agent SERDs. In data from EMBER-3, looking at imlunestrant as a single-agent oral SERD compared to standard of care endocrine therapy. As we focus just on that single-agent comparison in the intention to treat population, there really was not much of a difference seen there with the SERD over standard of care endocrine therapy. But when you enrich for the ESR1 mutation, there was a significant improvement in median progression-free survival. I do want to call out once again that the EMBER-3 population was a very endocrine-sensitive population. Not all patients had seen prior CDK4/6 inhibitor. Some patients were treated actually in the first-line setting. Patients had not seen prior chemotherapy nor fulvestrant. We also have data from the EMERALD study. So elacestrant was the first oral SERD that we had approved for use in patients with ESR1 mutations. These patients had all seen prior CDK4/6 inhibitor. Many had seen prior fulvestrant. 20% had seen prior chemotherapy. And despite that heavily pretreated population, if you will, median progression-free survival with elacestrant was superior consistently across subgroups. When you start to enrich for those patients that appear to have endocrine-sensitive disease, so those patients who did not see prior chemotherapy, median PFS was around 5.5 months. When you look at those patients who had prolonged time on their first-line endocrine therapy with CDK4/6 inhibitor of more than 12 months, again, enriching for endocrine-sensitive disease, their median PFS was about 8 months. Looking at co-mutated patients with PI3 kinase mutations, those with visceral disease, those with prior fulvestrant, those with prior chemotherapy, and across the board, elacestrant outperformed single-agent endocrine therapy. Here we have data for alpelisib, the first PI3 kinase inhibitor that was approved for use with fulvestrant in patients in the second-line setting or later. And in this patient population, median progression-free survival was improved with the addition of alpelisib. Although, again, these are patients that were more endocrine sensitive, if you will. We also lack a lot of data about the subset of patients who had ESR1 mutations. So again, very difficult to extrapolate the data to our patient populations today. We also have Capitello data, which looked at using the AKT inhibitor capivasertib with fulvestrant in the second-line setting. Here, again, the addition of that AKT inhibitor was better than single-agent endocrine therapy. In general, these patients had shorter median progression-free survival by nature of the presence of one of these pathway alterations. And we have not seen the subset of patients in that primary population that had an ESR1 mutation. So again, difficult to extrapolate to how we manage the dual mutation patients that have both an ESR1 mutation and a PI3 kinase or AKT pathway alteration.
One group of these biomarkers are intrinsic mutations. What does that mean? That means that these mutations are there early on in the course of the disease. So you'll find them even in the primary tumor tissue at the initial diagnosis. What falls under these intrinsic mutations is alterations in the PI3 kinase, AKT, and PTEN pathway. The other group of biomarkers are acquired mutations, and the best characterized acquired mutation in luminal type breast cancer really is mutations in the ESR1 gene. The ESR1 encodes for the estrogen receptor, and if we look at the primary tumor, we'll find mutations, activating mutations in that gene in only 1 or 2% of patients. So they are at a very, very low prevalence. But as treatment increases they become more and more frequent. And this is because they're acquired under the evolutionary pressure of endocrine deprivation. So aromatase inhibitor therapy predominantly. And the longer a patient is exposed to an AI, the higher the chances really are to picking up these ESR1 mutations. The ideal sample to test for ESR1 mutations is the liquid biopsy, to have a plasma sample send off to a lab. It doesn't really matter what type of technology is then used to identify these mutations. That could be an NGS panel in the liquid biopsy. It could also be a digital droplet PCR. It's important to look at the liquid biopsy sequence for the ESR1 mutations. And if they're wild type, reconsider at the next progression to test again. Don't test in the archival tissue of the primary tumor. It doesn't work. You'll find 1% of ESR mutant positive patients. I think these are the main take-home messages from my part in the symposium. And I think this very, very nicely aligns with what we heard about the activity of oral SERDs in second-line metastatic luminal-type breast cancer. Thank you for your attention.